Thank you, Dr. Alia, for the very good lecture on the topic. I'll move on to the next presenter. I will give a brief introduction. Dr. Chung served as a senior lecturer and spine surgeon in Department of Orthopaedic Surgery, and he obtained his medical degree from USM and awarded Dean's List in his university. And he attained his Masters of Orthopaedic Surgery from University of Malaya and was the top student and received the Best Student Award. He is an active researcher and has many publications in both local and international journals, and he was awarded numerous awards such as the Scoliosis Research Society Educational Award, Japanese Society for Spine Surgery and Related Research Gold Prize Oral Presentation Award, Asia Pacific Orthopaedic Association Young Ambassador Award. Dr. Chung is also an active member of various professional spine societies such as the Malaysian Spine Society, Asia Pacific Spine Society, AO Spine, and Scoliosis Research Society. And recently, he has been appointed as a scientific chairman for the upcoming International Malaysia Spine Society Scientific Congress. So without delay, I will let him continue with his presentation on minimal invasive stabilization in spine fractures.
Good morning, everyone, ladies and gentlemen. Thank you very much, Prof. Chiu, for the great introduction. So I'll start my slide share. All right. Okay. Morning, everyone. So the topic that I'm going to present today is minimally invasive stabilization in spinal fractures. All right. So I have no disclosure. So most of the time, the conventional way of doing the spinal surgery is to do an open surgery, whereby the skin is incised, muscles are detached and dissected from the spine to expose the spine for screw placement. However, in the advent of technology, new technologies are coming on, and therefore we can actually perform a minimally invasive stabilization via putting percutaneous pedicle screws, okay, making a keyhole incision through a small hole in order to insert the screws into the spine. So this is actually a minimally invasive technique to insert pedicle screws. What are the advantages of MIST via percutaneous pedicle screws? There are several advantages. Number one, there will be less soft tissue trauma. The skin incision will be smaller, less blood loss. Patient can go for earlier rehabilitation and requiring shorter hospital stay, less pain, and most importantly, this technique will preserve the muscular attachment for better function. As you can see the photos on your right-hand side, all the screws were inserted via a keyhole incision, right? There's no central long 20 to 30 centimeters long incision at the center, all right? So we can actually perform this technique using a keyhole incision to stabilize the spine. However, there are several questions that we need to ask ourselves before starting this surgery. So it is safe to use percutaneous pedicle screws. Our center has actually compared percutaneous pedicle screws and conventional open pedicle screws in human cadavers and found there was no difference. We also performed a CT scan analysis of 2,000 screws and found that the accuracy of percutaneous pedicle screws of up to 90.6%, with only 1.9% of critical perforation, whereby critical perforation has a higher risk of neurological injury. Is this safe, or is there any problem using percutaneous pedicle screws in Asian patients? Our center compared percutaneous pedicle screws insertion between European and Asian patients and found there was no difference, both in the thoracic spine as well as in the lumbar and lumbosacral spine. And third question is that which level has the highest perforation rate? So this study showed that T1 has the highest perforation rate, followed by T4 and F1. So in T1 level, this is because of the morphology of the T1 pedicle. The T1 pedicle is the most medially angulated as compared to the rest of the thoracic spine. So therefore, if the skin incision is made very medially, the screw placement will be trajected downward anteriorly and therefore risking anterior screw perforation. The screw in T1 has to be placed medially as much as possible. Therefore, the skin incision for T1 pedicle, percutaneous pedicle screws is very important. It has to be placed along the trajectory of the screw insertion. Secondly, it is because of the eye image. Because in percutaneous pedicle screws, we are using fluoroscopy guidance. Therefore, the C-arm or II image is very important. In the AP view, most of the time it is blocked by the endotracheal tube. And in the lateral view, it is hardly to obtain a good image because it is blocked by the shoulders. Secondly, T4 level has the second most highest screw perforation. This is because of the morphology of the T4 pedicle. In this region, T4 has the narrowest pedicle width as compared to the other thoracic vertebrae. So therefore, the risk of screw perforation is much higher in T4. Lastly is S1. The fourth question is that we are going to ask which pedicles are the most dangerous in terms of percutaneous pedicle screws and in terms of neurological injury. So L5 level has the highest risk of a neurological injury. This is because of the morphology again. In the upper lumbar vertebra, the body shape is much rounder and the pedicle is less angulated, and the spinal canal is more cylindrical. Therefore, screw placement in this region has a lower perforation rate. However, in the L5-S1 vertebrae, the spinal canal is in a trefoil shape. Therefore, putting a screw following the conventional way of putting a fluoroscopic guided percutaneous pedicle screws, the risk of neurological deficit causing a nerve root L5 traversing nerve root injury is much higher. All right. So this is a diagram, CT scan MRI showing a dysplastic L5 pedicle. As you can see that the pedicle is very small with a very trefoil-shaped spinal canal. So how do we solve this? In this kind of this area whereby the presence of a trefoil-shaped canal, we will insert the guide wire not until the middle wall, but until the center of the pedicle. Therefore, putting the screw along this trajectory will have a lower risk of nerve root injury. So next, I'm going to show you a few case examples of the utilization of MIC via PPS in spinal fractures. Firstly, MIC can be used to achieve indirect reduction of the fracture size. So this is a 63-year-old patient with an L1 burst fracture. In a CT scan, MRI shows that there's a kyphotic deformity with a lateral pulse fragment in the axial cut of the CT scan. And also, patient has got a coronary injury with a Frankel C neurological deficit. So in this technique, we will insert monoaxial screws in the adjacent vertebrae next to the fracture site. Monoaxial screw means that the screw head and the screw shaft does not move. It is fixed in as one unit. All right. In the distal vertebral level, we will insert polyaxial screws whereby the screw head is freely mobile. Next is that we will insert a rod which is pre-contoured in the near straight alignment. And this is how we insert the rod via a keyhole incision, because we do have a lot of patients and doctors ask, how do you insert the rod via a keyhole incision? So this is how we insert it. We will insert from either cephalate to caudal or caudal to cephalate, depending on the region of the fracture. All right, so we tunnel it along the screw shaft, screw sleeve. All right, and we will check whether it's within the screw sleeve or not. All right, this is how we do it. So then we will insert the screw nut, all right, into the screws, and tightening of the screw nuts with the rod onto the monoaxial screws adjacent to the fractured vertebra will form a 90-90 screw rod construct, and this will enable correction of the anterior vertebral height. Right? So next we will use a distractor to perform a distraction maneuver onto the monoaxial screws, and this will actually increase the posterior vertebral height, as shown here. Okay, all right. So this surgical technique, we have actually reported our surgical technique and results. We compared the usage of monoaxial screws versus all polyaxial screws in the thoracolumbar fractures. All right, and we found that the monoaxial screws, which is inserted adjacent to the fracture level, provide significantly better fracture reduction in terms of the kyphotic angle and vertebral height correction as compared to polyaxial screws in the thoracolumbar fractures. So back to this patient, before reduction, the local kyphotic angle was about 20 degrees, and after reduction, it has reduced to 7 degrees, which is acceptable. These are the post-op radiographs, and pre-op and post-op CT scan shows that there's a reduction in both the anterior and posterior vertebral height as well as the kyphotic angle. The retropulse fragment has been reduced as well. These are the post-op CT scans showing screw placement. Okay, secondly, it can be used for multi-level fractures. In this patient, who is a middle-aged man with chest injury and multi-level spinal fractures, in this kind of patient, the aim of the surgery is to stabilize the fracture, okay, so that the patient can go for rehabilitation much earlier, as well as to reduce and to minimize the perioperative mortality and morbidity. Right, so we perform percutaneous pedicle screws in this patient. Another patient, a 17-year-old girl, falls from height with 5 levels spinal fractures from T6, T8, T11, T12, and L3. So if we were to perform an open surgery in this patient, it would be a massive surgery from the neck down to the pelvis. All right, so in this patient, what we do is that we perform an MIC via percutaneous pedicle screws, spanning across all the fractures, all right, from T4 to L4. This patient also has got lung injury and neurological deficit as well prior to the surgery. All right, so CT scan shows fracture union at 9 months post-op, as shown in the red arrows over here. Okay, the third case example that I'm going to share is that MIC via PPS can be used to bypass injured soft tissue area. It's the same patient from same patient as just now. This patient also has got a deep laceration over the paravertebral soft tissue area, all right, deep until the muscles. So if we were to perform an open surgery, the risk of infection is very high, very high. All right. So we perform MIC, all right, and 3 months post-op, all the wounds have healed. The patient has got a few bouts of infection over the wound, but at 3 months, the wounds has healed already. All right. It can be used for upper thoracic fractures as well. So in this patient, a 20-year-old girl, MVA, with T5, T6 fracture dislocation and complete spinal cord injury and a right lung injury. So in this patient, okay, we can use the laser beam guided percutaneous screw placement to place the screws in the upper thoracic spine. Right, as I said just now, because upper thoracic spine is very much more difficult to insert the screws because of the difficulty to get a good eye image. So therefore, this study has reported an accuracy of 87.7%. So in this technique, we use the C-arm oblique view. So the angle of rotation should correspond to the T1 pedicle medial angulation, which is measured preoperatively in the CT scan. So in this trajectory, we can insert the trocar. So we get a bull's eye view of the T1 pedicle in the oblique view and mark the center. The trocar should be inserted to the center of this T1 pedicle. After that, we rotate the II to the opposite side to check the depth of the trocar. Then, therefore, we insert the wires and the screws. Post-operatively, patient has acceptable fracture reduction. MIC can be used for patients with osteoporotic fractures. In this patient who was an 89-year-old lady with osteoporotic vertebral compression fracture of T12 with conus medullaris injury. This patient will perform MIC and cement augmentation at the fractured vertebra. Another patient, 80-year-old lady with OBCF of L1 and conus medullaris injury as well. In this patient, we also perform MIC and cement augmentation at the fractured vertebra. At 9 months post-op, CT scan revealed fracture union. Lastly, MIC can be used for fracture in ankylosing spine. All right, ankylosing spine means that the spine is stiff and has been fused due to a few reasons. Either it's ankylosing spondylitis or diffuse idiopathic skeletal hyperostosis. This is a 70-year-old patient underlying ankylosing spondylitis with T11 fracture. The CT and MRI shows a large intravertebral cleft in the fracture site. So we perform a long segment MIC with 8 screws above and 8 screws below the fracture site. And at 1 year post-op, fracture union was achieved. This is an interesting case. A 78-year-old gentleman underlying ankylosing spondylitis and OPLL. OPLL means ossified posterior longitudinal ligament in the cervical spine. This patient has got 3 problems. The first one is the C3-4 spinal stenosis causing cord compression, C5 fracture, as well as the T5 fracture. So this really posed a lot of challenges to us. So we have a great discussion and we finalize our plan and we perform an open surgery to open decompression and fusion in the cervical spine for the C3-4 and stenosis and C5 fracture. And we extend the instrumentation to the thoracic spine, and the thoracic spine, the pedicle screws in the thoracic spine was placed percutaneously. And we inject cement to the T5 fracture. Post-operatively, patient neurological deficit has improved. So the third patient, this is a 73-year-old lady who has got a fused spine secondary to a scoliosis surgery, which she has done during her adolescent stage. Right? She had a fall and she had an L2 fracture. So in the CT scan over here, show that there's a chance fracture over the L2 in a fused spine. So then again, this patient mobility has got a deformity of the spine. If you can see the X-ray here, she has a coronal imbalance and also sagittal imbalance as well. So therefore, in this patient, we are not going to correct the deformity. The patient has been living with this deformity for most of her life. So the aim of the surgery is to stabilize the fracture for fracture union. So therefore, in this patient, we perform MIC via percutaneous pedicle screws, right? And bypassing the rod. And at 1 year post-op, the fracture union has achieved. So we published our study, a short series on comparing minimally invasive versus conventional open surgery for fixation of spinal fractures in ankylosing spine. So in this study, we found that in the open surgery, the operation time is very much longer than the MIC group, and the blood loss was 4 times higher. However, there was no significant difference in complication rate, union rate, and hospital stay. So we concluded that, in this study, we concluded that MIC provides a favorable as well as acceptable result as compared to the conventional open technique than a spinal fracture fixation in ankylosing spine. So what are the complications? Number one is wire perforation. So wire perforation is a disaster because it can risk great vessel and bowel injury in the abdomen. So we have to be careful, especially when we are inserting wires in the osteoporotic bone and ankylosing spine. So Professor Ken Ishii has introduced a novel technique, S-wire, to reduce the risk of wire perforation. In our center, what we do is that when we are inserting the screw along the wire, we always have to look at the wire and the fluoroscopic image to prevent any inadvertent wire perforation. Second is infection, right? The possible causes of infection in MIC is that, as I mentioned just now, MIC should have a lower risk of infection, but there are few possible causes that we get infection in MIC wounds is because we make a very narrow stab wound. So when we insert the screws in, it can squash the fascia as well as crushing the muscles. So how to avoid it? We should insert the rod as deep as possible beneath the fascia. So this will reduce the risk of squashing the fascia and crushing the muscles. However, managing a small infected MIC wound is still much better than managing an infected large open wound, right? So thirdly is screw pull out. Okay, this is an 80-year-old lady with ankylosing spondylitis and osteoporosis with a fractured T12. We perform MIC from T8 to L4. However, 1 week post-op, the right-sided distal screw pull out. All right. So what happened is that we found out that if the rod, the screw sleeve was not placed parallel to each other, and we contour the rod following the screw sleeve, the rod contouring will not be contoured well following the alignment of the spine. So therefore, in this kind of screw contouring, all right, when the rod contour is not contoured well, there's a higher chance of screw pull out. So the screw sleeve should be placed parallel, and therefore when the rod contour is contoured well following the alignment of the spine. So in conclusion, MIC via percutaneous pedicle screws insertion is a safe and useful technique alternative to conventional open surgeries in the surgical treatment of spinal fractures. Thank you.
Thank you very much, Dr. Chung. So, okay, I think maybe we'll go on to some questions posted on the Q&A by Professor Sarah. Can this technique be used to rescue the spinal cord from compression, or is it still safer to do conventional surgery?
Thank you very much, Prof. Sarah, our lovely teacher. Right. So, okay. So, there are two reasons for neurological deficit. Number one is that a spinal cord injury, neurological deficit. Number one is that it is due to a static compression, whereby there's a retropulse fragment or buckling of the ligamentous stable compressing the spinal cord. In this patient, we will do a decompression. So after following the MIC screws, we can always perform a mini open decompression over the fracture site to decompress the spinal cord. All right. In the cases that I shared just now, especially in those with OBCF, that is due to a dynamic instability, whereby when the patient is lying down, there is not much of spinal cord compression from the fracture site. But when the patient sits up, okay, the patient moves, the fracture site moves and compresses the spinal cord. So that is due to dynamic instability. So therefore, in those cases, we can just perform MIC without any decompression. So we still have to look at the CT scan and MRI to decide. Thank you, Prof. Sarah, for your question.
Yeah, so another question from Prof. Sarah as well. When you say squashing, do you mean by compression causing necrosis of soft tissue, thereby leading to infection?
Yes, Prof.
Yeah. So there's no more questions. So thank you very much, Dr. Chung. Thank you for sharing your lecture on this minimal invasive stabilization surgical technique. With this, I think we will end the breakfast session. Thank you for joining us.
Thank you, everyone. Thank you for your time. Thank you, Prof. Chiu.